Hi everybody, Dr. Manny here. Welcome to Chest X-ray Part 2, and this will be reviewing white or radiopaque images on an AP film. Okay, the objectives for this session are to review and identify the anomalies, diseases, conditions which create white images or radiopaque images or images that have got increased density on a chest X-ray. You have to remember normal whiteness is radiopacity in the right places. And this is dealing with tissues and organs, such as the mediastinum, the heart shadow, and the liver, which is normally below the right hemidiaphragm. All these organs contain blood, fluid, tissue, and it's the blood vessels that are full of blood that will create these images as well. You also have to remember abnormal whiteness. This is radiopacity in the wrong places. Remember our previous too white, too big, in the wrong place. And this deals with tissues and organs such as the mediastinum, which includes the heart shadow and blood vessels. Remember wrong place. Here's dextrocardia, which we'll be reviewing in later sessions. But you've got the liver under the left hemidiaphragm, and you've got the stomach under the right hemidiaphragm. Then you've got underpenetration. Underpenetration, a technical problem, and this will increase the whiteness on your chest X-ray, or it will make structures appear whiter than they normally are, which could obscure or hide certain things that you might be looking for. So, what is this whiteness then? Whiteness occurs due to increased density of an intra-thoracic structure. It can be homogenous, which means the same whiteness, or it can be heterogeneous and patchy. Technical whiteness is due to the way the image or the photograph or the chest X-ray was taken. It's a technical issue, and this deals with underpenetration, which means not enough X-ray beam has been used by the radiographer, or the person being X-rayed is too far away from the X-ray beam, which decreases the dose getting to the film. Let's review a unilateral or a one-sided pleural effusion on an AP anterior-posterior film. A pleural effusion is an abnormal collection of fluid between the layers of the tissue lining the one lung, the pleural cavity, or the pleura, and the wall of the chest cavity. Typically, it's homogenous in whiteness, the same. There's blunting of the costophrenic angles if the person being filmed is in an erect position. There's something that's called the meniscus sign, which basically means crescent-shaped. So there's a crescent-shaped shadow in the periphery, and there can be mediastinal shift. So if you look at the X-ray, you've got a moon-shaped shadow. You may or may not have mediastinal shift, and you've got blunting of the left costophrenic angle because there's fluid sitting there. Fluid is white, it's tissue. Normally the lung should be black, but it's full of fluid. Here's an example of a bilateral pleural effusion. And basically it's exactly the same, except it's happening on both sides. An abnormal collection of fluid between the layers of the tissue lining of both lungs or pleural cavities and the wall of the chest cavities. It's homogeneous in whiteness or as a radiopaque or opacity, and there's blunting of the costophrenic angles if the person is having the film taken in an erect or semi-erect position. And there's the classic meniscus sign, which is characterized by the crescent shape in the peripheries. Mediastinal shift will be difficult to determine in bilateral, depending on how much fluid is on each lung. If we were to review the pleural effusion on a lateral chest X-ray, you would see similar features: the meniscus sign and blunting of the costophrenic angle. It's homogenous in its radioopacity, but there again you can see the meniscus or the crescent-shaped sign and blunting of the costophrenic angles. Increased whiteness. In the decubitus position for a pleural effusion, well, the decubitus position, just like the lateral chest X-ray, is really just to identify and confirm what you already know from the AP or the PA film. And this can identify and confirm dependent fluid levels, because in this situation we've placed the person being filmed on their left lateral position or their left side, and we wait 10 to 15 minutes for the fluid to move into a dependent position. It won't move straight away. You have to give time for now the fluid to move into that position before the X-ray is taken. Decubitus. This is a hemothorax. Remember, hemothorax, or heme is blood. So this is a collection of blood within the thorax or the pleural space. This chest X-ray has been taken with someone who's obviously had a bullet wound. The bullet is still there, a foreign object, in the right chest. And a hemothorax is increased homogeneity or radioopacity due to, as I said, a collection of blood in the pleural cavity. This person has been taken a supine film, so again it's dispersed over the whole upper, lower and middle lobe area. If it had been taken in an erect position, there may be a fluid level, but maybe the patient's hemodynamically unstable after having been shot in the chest and bleeding considerably. Here's an example of pulmonary tumors or a mass on an AP film. This is a left-sided mass or increased whiteness. So on this film there's increased homogenous radioopacity or tissue in the lungs because of an abnormal tissue growth in the lungs. Lungs are normally black. Lungs are normally filled with air. There's some mass here for some reason which is increasing whiteness. And remember, the chest X-ray is just one of the first investigations that will be done. There will probably be a CT done, maybe an MRI done, and this will result in possibly a biopsy. But you're just identifying that you've got increased whiteness for some reason on the left upper lobe. Again, another example of a big mass, probably on the left upper lobe, and this seems to be pushing the heart over. You've got mediastinal shift and you've got tracheal deviation. So this is probably a big mass. Here's an example of another mass, a coin-shaped lesion. Any lesion that is shaped like a coin would be referred to this, or you could just call it a mass. And it's all because of abnormal tissue growth in the lungs. But this will require further investigation. Chest X-ray is just the beginning. There's another example of a coin-shaped lesion. Here's an example of multiple tumours or masses or lesions throughout the lung fields, predominant on the right lung, upper, middle and lower lobe, and these are probably metastases which will require further investigation, CT, biopsy, MRI. Then you've got atelectasis or lung collapse. And lung collapse or the radiopacities are heterogeneous and typically patchy. And typically they're associated with air bronchograms in the bronchioles distal close to the alveoli. A normal air bronchogram is only seen in the trachea, the carina, the bifurcation, and the primary bronchi, right and left. Anywhere else is classed as being potentially abnormal. Here's an example where you've got right upper lobe, whiteness, increased opacity, patchy, and you can see terminal bronchioles here following from the primary bronchioles, which is abnormal. More severe, you've got right and left, upper lobe, middle lobe and lower lobe, atelectasis, and you can see the air in the bronchioles. This is an air bronchogram. This is abnormal. This indicates that air is stuck, if you want to look at it like that, in the distal bronchioles or the alveolar bronchioles. It can't get out into the alveoli because of some reason. Mucus plugging, atelectasis, which is the lung collapsed. Could have pneumonia. Here's an example of atelectasis in the upper lobe. You can have it in the right upper lobe, which is what this X-ray is demonstrating. And the affected lobes have increased radiopacity. They're too white, but they're patchy, heterogeneous. And they can be associated with air bronchograms, which is air in the bronchioles. Here's an example of left upper lobe atelectasis. And you don't have to be an expert to know and identify that something's wrong. On physical assessment, the patient will probably have something wrong as well. They may be demonstrating shortness of breath. The chest X-ray is just to confirm what you already found on their physical assessment or their history. Here's an example of middle lobe atelectasis. The middle lobe is atelectic. It's affected the middle lobe. You can see increased whiteness and patchiness in the right middle lobe. This is heterogeneous. S2 can be associated with air bronchograms, which is just air in the bronchioles, which typically you don't see in a normal chest X-ray. We only see it in the trachea, the carina, and the primary bronchi. Here's an example of atelectasis in the right lower lobe. And the left lower lobe. In the left lower lobe, it's difficult to identify, and you identify it by seeing a triangular density at the left base of the heart. Now, on an AP film, this is unusual. It's difficult to see on an AP film because an AP film alters the intra-thoracic structures a little bit. But if you do see it in a left lower lobe, the atelectasis is seen as indicated by this triangular density at the left base of the heart. But typically we would leave that for the radiologists to identify. They're the experts. The affected lobes have an increased radioopacity, they're too white, and it's a patchy whiteness, heterogeneous. Now we have an example of bilateral atelectasis. And this is where both lungs, the upper, middle and lower lobes, are affected. The radiopacity is patchy or heterogeneous. You can see an air bronchogram indicated by the arrows extending right down into the middle and lower lobes. Lung consolidation just means the lung is solid for some reason. There's stuff in there. It can't be moved. And this occurs when the air that fills the small airways is replaced with fluid, such as pus, a purulent fluid like pneumonia, blood, gastric contents, because it's been inhaled, or water, drowning. So this is a radiopacity that's heterogeneous and patchy, but it does require further investigation, as it will be. This patient here that you're looking at with right upper lobe consolidation would be quite sick. Typically, because it's solid, there's no tracheal deviation, there's no mediastinal shift. It just sits there, but air can't get in there. I've included pneumonectomy as well, because pneumonectomy could be something that now causes increased whiteness. But you would know that the patient had a pneumonectomy from their history, and you would know that they had a pneumonectomy from their scarring or their surgical scars, which they would have on physical assessment. Pneumonectomy is complete surgical removal of a lung, or even sometimes just a lobe, with the following chest X-ray consequences. The remaining lung hyperinflates, compensates. The trachea deviates to the affected side because there's nothing stopping it from moving. The mediastinum shifts for the same reason. Abdominal organs seem to move up, push onto the diaphragm, up into that affected side, and the radioopacity that's involved on the side is homogenous. You may even see staples or sutures on the chest X-ray. Pulmonary edema basically means the lungs are becoming edematous. And typically, this can be related to heart failure, or it can be related to some non-cardiogenic situations such as acute respiratory distress syndrome, which we'll be looking at. Pulmonary edema is typically a condition associated with excess fluid in the lungs. And this is where fluid collects in the alveoli, whether it's now directly in the alveoli or the interstitium. And because the fluid collects in the alveoli, gas exchange is impaired, and it makes it difficult for the person to breathe. The radioopacity, however, is heterogeneous and patchy. Pulmonary edema occurs because of congestive heart failure. And congestive heart failure occurs when the heart muscle doesn't pump effectively, and the chest X-ray findings are cardiomegaly, or a large heart. You can have what are called Kerley's ABC lines, which we'll be reviewing in more detail in a later workshop, but we will be looking at Kerley B lines today. Well, in this session anyway. The upper lobe, there's pulmonary venous congestion. There's what's called a bat wing appearance at the central part of the lungs or close to the heart, and it can be associated with pleural effusions. But the radioopacity is heterogeneous and patchy, and you would know the person was in heart failure with their history and their physical assessment. If we look at Kerley B lines are located at the costophrenic angles, out in the periphery, and in the lower lobe region. And it's associated with venous congestion and interstitial edema. And these were lines that were identified and associated with congestive heart failure. ARDS, acute respiratory distress syndrome. And this occurs when fluid builds up in the alveoli of the lungs. And the chest X-ray features are usually acute or considered to be chronic. The chest X-ray features typically develop over the first 12 to 24 hours after the initial lung insult that's caused the problem. And it's interesting that the chest X-ray changes occur later than the clinical changes, which basically means the patient is sick on physical assessment, but the chest X-ray looks healthy. However, the radioopacity will become heterogeneous and patchy. So let's review. Look, this is one. The chest X-ray looks reasonably okay. The patient, however, is sick. Then over the next 12 to 24 hours, the X-ray starts getting sicker. There's capillary leak, fluid into the alveoli, and you're starting to get heterogeneous, patchy, increased opacities. The X-ray continues to get worse, so does the patient on physical assessment, until the end result is basically an X-ray that is really difficult to see any blackness at all or radiolucency, because the lungs are really full of fluid. If we review another chronic lung condition, this is pulmonary tuberculosis. And pulmonary tuberculosis has infiltrates and consolidations and developed cavities that are often seen in the upper lobes. The radioopacity is heterogeneous and patchy, and the abnormalities on the chest X-ray may be suggestive of tuberculosis, but they're never diagnostic. You need further investigations, as you do with all these conditions. The chest X-ray is just an initial investigation which leads to other investigations that will become diagnostic. Then you've got chest trauma. Well, we know the person's got chest trauma because they've been involved in a motor vehicle accident, or they fell off a building, they fractured their ribs. So with chest trauma on a chest X-ray, typically the fractured ribs could cause bleeding, which results in radioopacities that could be homogenous or heterogeneous. You could develop lung contusion. You could develop a hemothorax. However, they're typically associated with a pneumothorax as well. So you could have both, because if you had fractured ribs, you would probably damage the lung with the splintering of the bone fragments, which could cause pneumothorax and hemothorax. As you can see on this chest X-ray, on the left side, there are numerous posterior rib fractures, and you've got increased whiteness on that left side, which is probably related to bleeding. So let's review. Always remember to evaluate the patient's X-rays with their history, their physical assessment findings, the clinical findings, serial X-rays, and remember the technical quality of the X-rays: projection, orientation, penetration, rotation, and inspiration. So let's look at number one. What do you think? There's increased opacity and whiteness on the right side. There's no costophrenic angles on the right side, and you've got the classic meniscus sign in the right upper lobe. This is a right-sided pleural effusion. What's happening in this X-ray? There appears to be a congested heart. There appears to be congestion on the pulmonary area on both sides, the hilar, which is resulting in a typical bat swing appearance. There seems to be increase in vascular markings, so this could be congestive heart failure. Have a look at this X-ray. There seems to be whiteness, or too much, or too big, or too white on the right upper lobe. And if that's happening here, this could probably be either atelectasis or maybe even consolidation. This is now right upper lobe atelectasis, collapse. What do you think about this one? The problem's obviously on the left side, the left lung. You've got a meniscus sign in the right upper lobe. You can't see any costophrenic angles or diaphragm, tissue to tissue. And there seems to be a big problem. It seems to be pushing the trachea over, and it seems to be pushing the heart over. So you've got tracheal deviation and you've got mediastinal shift. This is probably a huge left-sided pleural effusion. Well, what do you think about this one? This is going to test you. I'll just give you a few moments. What do you think? There's symmetry. Heart looks okay. Penetration looks okay. Everything seems to look okay. So it's probably a normal AP chest X-ray. Okay, what do you think? There's obviously a problem on the right chest. You've got increased whiteness or opacity in the right and middle lobes. This could be Atelectasis, which is typically patchy, but I think the film is a little bit underpenetrated, which makes it harder to see. But that's the problem when the film hasn't been taken correctly. But this could be right upper lobe Atelectasis with a possible pleural effusion. But you've got to remember the element of now underpenetration as well. Well, this is a pretty sick looking chest X-ray. You've got middle lobe and lower lobe involvement and upper lobe involvement throughout the whole X-ray. You've got an air bronchogram effect. It's possibly underpenetrated as well. But if I said to you here that this patient is really, really unwell, then you might come up with an interpretation that could indicate probable acute respiratory distress syndrome. But the history and the physical assessment and the laboratory results are really important as well. Okay, very white chest X-ray. Looks pretty normal, but it's too white. So what do you think? Yep, I probably agree with you. This is an underpenetrated chest X-ray. Okay, what do you think about this one? Yeah, you've got lots of lesions. You could call them coin lesions if you wanted to. But you've got bilateral masses in both lung fields. Probably metastatic lung disease. And last but not least, there seems to be a mass in the right upper lobe, which you can call a coin lesion in the right upper lobe. Okay, that's the end of chest X-ray interpretation part 2. If you found this of any benefit or interest, or it entertained you, or you learned something from it, move on to part 3, chest X-ray interpretation, and look, any of the other Dr. Manny Learnshops that are available on YouTube. And look, sure, let me know what you think. Thanks a lot.